It is our honor to welcome our valued guest, Dr. Katerina Kybicova, one of the leading experts in Lyme Borreliosis and other tick-borne diseases. For those who did not yet have pleasure to meet our main speaker, Dr. Kybicova is the head of the National Reference Laboratory for Lyme Borreliosis, which is part of the National Institute of Public Health of the Czech Republic and falls under the Center for Epidemiology and Microbiology. The reference laboratory and Dr. Kybicova herself thus stand behind diagnostics, guidance, and training of specialists in medical microbiology, monitoring and analysis of especially tick-borne diseases, and many other activities and collaborations with international institutions such as the ECDC or WHO, for example. A part of this, Dr. Kybicova participates in a number of studies and projects related to the topic of Lyme and other vector-borne diseases. With that being said, I would like to pass the word to our guest, Dr. Kybicova herself.
Thank you for the invitation. Let's go to my presentation, and I hope that in the end of my presentation we can answer on the question why it's not easy to interpret the serological diagnosis of Lyme borreliosis. On the beginning, I would like to show you a little bit about Borrelia burgdorferi and s.r.o, because which is a really interesting bacteria. It's not only one bacteria, one spirochete. It's a little bit difficult. It's a complex of at least 22 species of bacteria, and we have a different situation in North America and in Europe. While in North America, mainly all the cases of Lyme borreliosis is caused by one bacteria, by Borrelia burgdorferi sensus stricto. They have also another Borrelia like Borrelia kurtenbachi, Mayoni, and Bissetti, but these bacteria cause a minority of Lyme borreliosis infection. Other situation is in Europe, because in Europe the most cases is caused by Borrelia afzeli, Borrelia garini, and also another one. We have a Borrelia burgdorferi sensus stricto, Borrelia bissetti, spilmani, bavariensis, and lusitania. It's a really strange situation. In this table, you can see how many Borrelia now we can know. The 10 of the 10 or 9 of this has a pathogeneity to human and cause human infection, Lyme borreliosis. Which is interesting, that the Borrelia have a different reservoir. As you can see, for example, Borrelia afzeli has a special tissue tropism to cutaneous and cause cutaneous manifestation like erythema migrans. The same tissue tropism has also Borrelia spilmani. And both of these bacteria have reservoir rodents. On the other hand, the most common Borrelia in the Europe is Borrelia garini, which caused mainly Lyme neuroborreliosis, and this Borrelia is transmitted by Ixodes ricinus from birds. So only a reservoir for Borrelia garini is birds. Now we can start with a diagnosis of Lyme borreliosis, and I can show you why there's no gold standard for direct diagnosis and also for indirect diagnosis. Why it is? Because antibodies are formed relatively late. IgM antibodies from second to fourth week after tick bite, and the IgG antibodies from later fourth to eighth week. If we tested patients in this gap, we can obtain false negative results during early examination of patients, for example, with early neuroborreliosis. And also half of patients with erythema migrans lack the antibodies. IgM antibody response is transient, and up to 50% of cases may lack. And on the other hand, up to 20 of healthy people have antibodies in our country and also in the Central Europe, even high titers. The antibodies of Borrelia persist for a long time, for many years after infection, IgG and also IgM response. Which is also important is that if the patient use antibodies, that the early antibodies can suppress the antibody synthesis, and seroconversion is lacking in these samples. And also, we cannot forget that it exists seronegative cases of Lyme borreliosis caused insufficient immune stimulation. Let's go to the direct diagnosis, and we can show you that there's also no gold standard for the direct diagnosis, because Lyme borreliosis, we can find Borrelia burgdorferi, the spider head, only in a small number in body fluids and also in tissue. For example, if the spider head goes to the bloodstream, there are only in a limited amount of time, only a few hours in the bloodstream. So these direct methods in only helper methods, and there is no uniform methodological protocol for them. So in Europe and also in North America, for diagnosis of Lyme borreliosis, we use 2 tiers serological testing. The first, as you know, the first test is a search test, enzyme immunoassay, or chemiluminescence immunoassays. And all the positive and borderline samples, it's needed to confirm by immunoblot in both classes, IgM and IgG. We can use also helper direct methods, like a second one. One of them is really useful, is molecular detection of Borrelia DNA, and the second one is a cultivation of Borrelia in liquid medium. We can have also other helper methods, like detection of quantiferon gamma or detection of chemokine CXCL13. Little about the Borrelia antigens, which is the antigens of early infection and advanced infection. Both are highly immunogenic, and both we can detect in IgG and IgM class. Antigen of early infection, the most important is outer surface protein C, which is anchored on plasmid, which is a factor of invasiveness and dissemination, and which is a very heterogeneous protein and has many serotypes. And we also in early Lyme borreliosis can detect 2 other proteins. One of them is flagellin, which is used internal fragment of flagellin because of a cross-reactivity. and this protein is encoded on chromosome. And the second one in P39, glycosaminopeptide receptor, which play a role of virulence and growth of Borrelia, and this antigen can respond in early and also in late antibody response. Antigens of advanced infections with highly immunogenics, we have many antigens of them. The most important is variable major protein-like sequence. Because this protein has a really high antigenetic variation, it's a surface protein, and this protein is expressed in every late Borrelia manifestation. The another important protein for advanced infection is the corrin binding protein P17, which confirm in infection. It's present in almost 100% in the late infection, like Lyme arthritis or late neuroborreliosis. The corrin binding protein has a tissue tropism to joint and has a regulation affected by 35 degrees Celsius. So for the first tier test, indirect methods, enzyme-like immunosorbent ELISA. It's used in many laboratories because it's easy to use and relatively cheap. We can use a commercial kit with a wholesale lysate of antigen or with a recombinant antigen. In the recombinant one is a use mixture of recombinant antigens, not only one, and it's measured spectrophotometrically. In the small picture on the right corner, you can see that this is a typical sandwich method, which advantages is objective semi-quantitative assessment automation, and little disadvantages like a false positive to some autoimmune disease or cross-reaction with another bacteria. The newest one, indirect methods, the first tier test, search test, is chemiluminescence immunoassay. On the market, we can find many commercial kits with recombinant antigens. It's a new development methods that use a chemiluminescence to detect and measure the target substance. This method is highly sensitive and specific assay that allow for the detection of low level of a target substance, not so high like ELISA. And the advantages is easy to automate and highly stable reagents, and these methods have similar disadvantages like ELISA. So because of these disadvantages, we need to confirm the first screen search test by the confirm test. The first confirm test that I present to you is an immunoblot, Western blot. In the market, we can find many commercial kits with individual antigens after separation or with recombinant antigen. The most common antigen is in kits is shown in this slide. You can see that it's different in EGM and EGG class. And which is interesting is evaluation of positive samples in North America and in Europe is because of the different Borrelia genospecies, genostrain that cause the Lyme disease. As you know, in USA, they have mainly Borrelia burgdorferi, sensu stricto. They cause all the borreliosis cases. So the evaluation is more strict. In USA, in EGM, positive results is needed 2 positive bands out of 3. And for EGG, it's needed 5 positive bands out of 10. The different situation is in Europe. As you can see, in EGM, at least one OSPC positive is enough to positive EGM results. And in the end of my presentation, I can show you which can have a problem with these positive results. And in EGG, at least 2 positive antigens is needed to the positive EGG results. Which is advantages of confirmed test Western blot? Individual antigens, higher specificity and sensitivity, and also testing cross-reactivity, for example, with treponema or co-infection with anaplasma. Disadvantages is a larger sample, and that the EGM have a less antigen than EGG. So let's go to the second confirmed test, the modern and new microblot array. It exists commercial kits with individual antigen in spots, in spots in the vial, and which is interesting that the same antigen is used in the EGM and EGG classes. And we can also test it co-infection, for example, with anaplasma, not only not only in one antigen, but in a few antigen. It is really important because time to time we can found co-infection with co-infection borreliosis with human granulocytic anaplasmosis caused by anaplasma. And it's important, especially in patients with neuroborreliosis, because this patient are treated by ceftriaxone, and this antibiotics is not usable for treatment anaplasma. So it's needed, it's really necessary to test it co-infection with anaplasma to change it, the treatment. In microblot array, we can also found the testing cross-reactivity, for example, with another spirochetes treponema. Here you can see also the significant antigens which is used in microblot array. For example, the specific VLSE antigen for specific Borrelia, for example, Borrelia garini, which is significant in early EGM response in cerebrospinal fluid, or another antigen like oligopeptide permeasa, which is marker of late disseminated Lyme Borreliosis, or on the other hand, internal fragment of flagellin, which is marker of early Lyme Borreliosis. New is also the protein neutrophilic activation A, marker of late Lyme arthritis. This microblot array methods, this converters, has many advantages, like a large number of antigens, same in EGG and EGM class, because the antigen of early infection can be immunogenic also in the late EGG class and vice versa. And the second advantage is also that we can use only a small sample of volume, automatization, and high sensitivity. Only disadvantages is that the method is not standardized. We can evaluate the results semi-quantitative or quantitative. Another indirect methods, the helper one of them is Lyme detect method, which is a detection of interferon gamma directly from the blood in combination with detection of antibodies. So combination of detection of humoral and cellular immunity advantages is used for detection of early disease before antibody formation. The sensitivity increase in the gap, in this gap of antibody formation. But there are many disadvantages like larger blood collection and processing, hold the processing more than 2 days. Then another indirect methods, which is also helper, is detection of chemokine CXCL13 protein inhibiting B lymphocytes, which is increasing concentration in CSF in early stages of neuroborreliosis and is helpful in these cases. Because in seronegative patients, and also for control of treatment effectiveness. The other indirect helper methods is not for clinical use because there's a lack of reliable methodological and clinical information. And now we can show the few slides about direct methods. Not many laboratories use cultivation. In our national reference lab, we use it because it's only one method that can demonstrate the really live Borrelia and active infection. But it's difficult. It's really difficult to cultivate Borrelia because Borrelia is nutritionally demanding and needs a really rich liquid medium, and it takes up to 12 weeks to cultivate it because Borrelia has a long generation period. We can cultivate the Borrelia from the body fluids and also from the tissue biopsies like the skin or myocard. The second direct methods, which is really useful, is molecular methods, the PCR. But we can think we must think to the few things which is important for PCR sensitivity. One of them is internal control. We need to use internal control because many PCR inhibitors are in the blood, urine, synovial fluid, or CSF. And PCR sensitivity can be reduced also by DNA degradation during the sample transport. So sensitivity of this method is relatively high, but only in synovium or in erythema migrans biopsy or acrodermatis chronica migrans. Acrodermatis chronica migrans atopic manifestation, and it's also higher in patients with a shorter duration of infection than 2 weeks after tick bite, and also in patients with neuroborreliosis with plocytosis. Specificity is close to 100%, and both sensitivity and specificity depends on the choice of primers, probe, and template quality, etc. The PCR methods are not methodologically unified, and there's no consensus for clinical use. So uniform methodological protocol of examination cannot be recommended for all laboratories. Which is important is that the positive PCR results is not evidence of active infection because a PCR is unable to distinguish between the DNA of living and dead Borrelia. What is the news in the last 10 years? New pathogenic Borrelia was found, like Bavariensis, which caused many cases of neuroborreliosis. And also a new news is in the pathogenetics and roles of selected antigens. It is found a new adhesion to vascular cell for decorin binding proteins for BBK 32 bindings to fibronectin, etc. And also the new role of oligopeptide terminals important for late Lyme arthritis and antigen virulence of cell division. It's also found a new antigen in arthritis refractory to the antibiotic treatment. And what is news in the diagnostics is a transition to recombinant antigen from the whole cell antigen, use the lipid membrane fraction, and also determination of antibody index in all neuroborreliosis cases as standard methods. In the last 10 years, we also use the multiplex methods like microarray and detection of quantiferon gamma. Before then, I show you the how to interpret the serological results. We must little look to the laboratory proof of different Borrelia manifestation, because what is important? For example, in erythema migrans, the laboratory proof is not recommended because, as you know, in the 50% of these cases, they don't. The patients didn't produce doesn't produce the antibodies. On the other hand, in patients with Borrelia lymphocytoma and or late and early neuroborreliosis or with musculoskeletal disorder, the detection of antibodies, EGM, and also EGG is really helpful, not only from the blood, but also from the CSF or from synovial fluid. And in this manifestation, we can also use the helper methods like PCR detection, DNA from Borrelia DNA from synovial fluid or from CSF. So let's about the interpretation of serological results. It's the interpretation is impossible without the knowledge of the patient's clinical condition, because up to 20% of healthy people have antibodies against Borrelia. On the other hand, the antibodies are formed relatively late, and we can obtain false negative results during the early examination of Lyme borreliosis patients, and also EGM response is transient. So it's really difficult to interpret the serological results, and there are two examples. The one is weak reactivity of EGG, that we often found in our laboratory, only positive VLSE antigen. Do not evaluate as a positive results because it's only persistent antibodies, which are to 20% of healthy people who did not get Lyme borreliosis, but only had a tick bite. The second sample is a isolate EGM reactivity, positive only OSPC antigen, without EGG reactivity. So, which is a recommendation, repeat testing to 2 to 4 weeks after. And if you obtain the same results, it's not an early infection, but only non-specific reactivity of the test with other antigens like bacterial or human. And for direct methods, interpretation as results, a positive PCR results is not evidence of active infection because PCR is unable to distinguish between DNA of living and dead Borrelia, and dead Borrelia may persist in the body for months after successful treatment. So now I would like to show you a few things from our lab. Our laboratory provides external quality assessment serology of Lyme borreliosis in the Czech Republic, 2 cycles per year. We provide it for 130 laboratories from Czechia and Slovakia, and the laboratory participate on serological diagnostics in 4 samples, newly from 2024 on 3 samples. We evaluate 3 parameter overall evaluation of EGM, EGG, and overall interpretation. Our success rate is in the last 7 years is relatively high, up to 100%. And why? Because in Czech external quality control, we sent samples, we sent some patient samples which are verified by all methods which is on the market in the Czech Republic, and they do not have too low level of antibodies or only one reactive antigen in both class. In these 2 graphs, you can see which test from which company test is more used in the Czech and Slovakia lab. So in the end of my presentation, I would like to show you a little bit about our small study in comparison of serological methods that we have 2 aims: determination of differences in antigen reactivity in groups of all patients, and determination of changes in antibody production and antigen reactivity in patients with early Lyme borreliosis before and 1 month after treatment. We have a relatively huge sample panels for testing methods, samples from patients with confirmed erythema migrans, samples from patients with confirmed early neuroborreliosis, patients with long-term follow-up with persistent antibodies, and also samples from healthy blood donors. So, which is the results of serological method? In the two first graph, I would like to show you the most reacting EGM antigens. in patients with early Lyme borreliosis, because we have two groups, patients with erythema migrans and patients with neuroborreliosis. And in these two graphs, it shows that in early responding EGM, we can see the same antigen, OSPC, and also flagellin and P38, and also VLSC in this early response. Patients with persistence antibodies show only their activity in OSPC and in OSPA antigens, and healthy blood donors respond only rarely. In this slide, you can see the most reactive in IgG antigens. There's a little bit different between patients with early Lyme borreliosis with erythema migrans and with neuroborreliosis, because patients with early Lyme neuroborreliosis show more antigens, more reactiving antigens in IgG, P39 and P58. And in the upper graph, you can see the response in patients with persistence antibodies. They show in the blue color many antibodies, but relatively in the low level. The healthy blood donors response it's really low level, also in VLSC antigens, as you can see in the lower graph. What is the results of serological method in the time? In this two graph, you can see the changes over time in patients with early Lyme borreliosis after 1 month. After 1 month, there's a differences is in EGG in both group of patients on the left graph, patients with erythema migrans, and on the right graph, patients with neuroborreliosis. IgG antibodies increase, especially in VLSE and OSPC. On the right graph, you can also see that the IgM antibodies after 1 month decrease, especially OSPC and P41 flagellin antigen. So how are the results? You can see in this poster, which was presented in 16th International Conference on Lyme borreliosis and other tick-borne disease in Amsterdam last year. And thank you for the attention.